Hi, I'm Ben Lahood, and I've made this video about posterior corneal astigmatism to help to simplify this topic that may seem complicated, but is actually quite simple. I hope that a better understanding of the optical principles and how we currently assess it will eventually lead to more surgeons feeling at ease incorporating posterior corneal astigmatism, and that this will lead to better visual outcomes for your patients. The cornea is not quite the simple curved surface we once dealt with. Although we have been aware of the contribution of posterior corneal astigmatism to total corneal astigmatism for a long time, it has only been in the past few decades that we have been increasingly accurate at measuring it, and only very recently have we been able to correct total corneal astigmatism more accurately. Our measurement of anterior corneal astigmatism has progressed steadily. Optical biometers are now very reliable and accurate at measuring anterior corneal astigmatism. If the posterior surface of the cornea matched the anterior surface exactly, this would be an adequate measurement. Unfortunately, it does not. Here you can see the anterior cornea highlighted in green, the corneal stroma in yellow, and the posterior corneal surface in blue. To measure total corneal astigmatism accurately, all of these components must be taken into account. Various methods are used worldwide. Scheimpflug imaging is widely used, especially in refractive surgery, but there are concerns about repeatability, and these images are rarely incorporated into cataract surgery calculations. Ray tracing and assessment of second Purkinje images is one newer technique currently available, and the incorporation of swept source OCT into biometry devices appears to be the latest method of assessing total corneal astigmatism. So many different techniques attempting to measure one thing indicates that none of them are perfect. Part of the problem is that the difference in refractive index between air and anterior cornea is large and makes the difference in curvature easy to measure. If the anterior chamber were full of air, the posterior cornea could also be more easily measured. However, the refractive index of aqueous humor is similar to cornea and makes the subtle difference in curvature difficult to detect. If we consider a with-the-rule anterior cornea, where the red line indicates a steep axis and the blue line indicates the flat axis, the points of focus are different for the steep and flat axes. Incorporating a posterior corneal surface with the steep axis in the vertical direction changes the total corneal astigmatism. The vertical posterior steep axis acts to neutralize some of the anterior astigmatism and brings the two focal points closer. If we now rotate the anterior cornea to give against the rule astigmatism, where the steep axis is horizontal, again the steep and flat axes give two focal points. The addition of the posterior corneal surface with a steep vertical axis this time, however, acts to magnify the total corneal astigmatism and pushes the two focal points further apart. This optical principle of adding the two surfaces together forms the basis of nomogram adjustment of anterior keratometry and also underpins calculators which take into account unmeasured posterior corneal astigmatism. We have developed population average statistics based on measurements of posterior corneal astigmatism in many thousands of eyes. We have a good estimate of the magnitude of posterior corneal astigmatism, and also that its steep axis is most usually orientated vertically, although it can be oblique or horizontal. Interestingly, the use of these statistics have often outperformed physical measurement of posterior corneal astigmatism when comparing outcomes from cataract surgery. We are now able to combine anterior keratometry with either a population average or physically measured posterior cornea to provide a value for total corneal astigmatism. Instead of aligning a toric intraocular lens with the anterior steep axis and providing potentially suboptimal unaided visual acuity, hopefully in the near future we will be able to measure the steep axis of total corneal astigmatism accurately for an individual and place their lens appropriately. This should result in optimal unaided visual acuity. I hope this video has helped to simplify posterior corneal astigmatism and motivate more surgeons to incorporate it into their treatment plans. If you have any queries or comments, please get in touch. Thank you for watching.